A 50-year-old woman started adjuvant tamoxifen 2 years ago after surgery for a T1, CN0, ER-positive, PR-positive, HER2-negative breast cancer. She was premenopausal at diagnosis, but has been amenorrheic for the past year while on tamoxifen. She is inquiring about switching to an aromatase inhibitor. The patient's amenorrhea for 1 year while on tamoxifen is sufficient evidence to confirm postmenopausal status and safely switch her to an AI. Answer: false. Clinical monitoring of menses alone is insufficient, as women may be amenorrheic on tamoxifen but still retain biochemical ovarian function. Biochemical confirmation, FSH and estradiol levels in the postmenopausal range, is required before switching to an AI. Studies have shown that recovery of ovarian function while taking an AI after chemotherapy-induced amenorrhea does not significantly impact disease-free survival. Answer: false. Recovery of ovarian function, resumption of menses or biochemical recovery, while on an AI has been associated with significantly lower rates of disease-free survival compared to those who remain postmenopausal. The risk of ovarian function recovery on an AI alone appears to be negligible in women aged 50 and older. Answer: false. The risk of recovering ovarian function with AI treatment alone has been observed even in women in their early 50s, although the risk is age-related and likely higher in younger women. Is it necessary to measure serum FSH and estradiol levels before considering a switch from tamoxifen to an AI in this patient? Answer: yes. To ensure safe use of an AI without OFS, biochemical confirmation of postmenopausal status via FSH and serum estradiol levels is necessary due to the unreliability of amenorrhea alone and the risks associated with AI use if ovarian function persists or returns. If biochemical tests confirm postmenopausal status and she switches to an AI, is further hormonal monitoring required? Answer: yes. It is advisable to monitor FSH and estradiol levels for several months after transitioning to an AI to ensure that ovarian function does not reactivate, as this can occur even after initial postmenopausal levels are confirmed. Was this patient considered low to average risk at the time of her initial diagnosis based on the provided tumor characteristics? T1 CN0. Answer: yes. Small, less than 2 centimeters, node-negative cancers in women over 35, where chemotherapy is typically not indicated, generally fall into the low to average risk category, for whom tamoxifen alone is the suggested initial therapy. A 39-year-old premenopausal, HR-positive, HER2-positive woman received neoadjuvant chemotherapy and trastuzumab-pertuzumab for a T2, N1, ER-positive, PR-positive, HER2-positive breast cancer. Post-surgical pathology revealed 1.5 centimeters of residual invasive carcinoma in the breast, but negative nodes. She remains premenopausal and requires adjuvant endocrine therapy. The SOFT trial provides robust data specifically guiding the use of OFS in HR2-positive patients who received modern HER2-targeted therapy. Answer: false. HR2-positive patients were a small minority, approximately 12%, in the SOFT trial, and only about 60% of those received HR2-targeted therapy, limiting the ability to draw firm conclusions for this specific population treated according to current standards. For premenopausal HR-positive, HR2-positive patients with residual disease after neoadjuvant therapy, omitting OFS is the preferred approach due to lack of specific data. Answer: false. For premenopausal patients with HR-positive, HR2-positive disease who have residual disease after neoadjuvant therapy, the addition of OFS with endocrine therapy in the adjuvant setting is suggested, grade 2C recommendation, despite limited direct data. If this patient had achieved a pathologic complete response, PCR, the recommendation regarding OFS would be the same, that is, strongly suggested. Answer: false. For patients achieving PCR after neoadjuvant chemotherapy for HR-positive, HER2-positive disease, either using OFS or omitting OFS are considered acceptable options depending on patient preference, as there are no data to inform the specific choice. Is tamoxifen alone considered an inappropriate endocrine therapy option for this patient if OFS is not used? Answer: no. If OFS is not used, which would be contrary to the suggestion for residual disease, but a possibility, tamoxifen would be the standard endocrine agent for a premenopausal woman. The core decision here revolves around adding OFS. Does the presence of residual disease after neoadjuvant therapy generally indicate a higher risk of recurrence compared to achieving PCR? Answer: yes. Residual disease after neoadjuvant chemotherapy, especially for HER2-positive or triple-negative breast cancer, is generally associated with a higher risk of subsequent recurrence and worse prognosis compared to achieving a pathologic complete response. Should this patient be counseled about the potential long-term health effects associated with premature menopause if OFS is initiated? Answer: yes. Inducing premature menopause via OFS, especially permanent methods like oophorectomy, can be associated with long-term health effects, including potential impacts on cardiovascular health and bone density, which should be part of the discussion.
What topic should we bite next? Comment below. Subscribe and hit the bell for instant updates. Explore our channel for more. Find more info at HemOncBytes.com. Stay current, stay curious.